Muy buenos días, sean todos bienvenidos y bienvenidas a este conversatorio sobre la restricción de derechos fundamentales en la pandemia por COVID. Bueno, sin duda es un tema pues de vanguardia que lo vamos a estar analizando en este conversatorio pues a partir de las herramientas metodológicas que se han tomado en diferentes países, en Alemania particularmente, sobre cómo decidir cuándo estas restricciones o estas limitaciones a los derechos están o no justificadas. Esto, pues sin duda, es algo que también tiene una implicación muy fuerte hacia México. Es por eso que el traer esta discusión aún en otro contexto muy diferente al de nuestro país, pues puede ser muy útil también para dar algunas pautas, sobre todo metodológicas, sobre cómo abordar esta cuestión. Por eso estoy muy contenta, además de pues todo este panel de lujo con estos profesores a quien realmente admiro por estar con nosotros pues estos 4 días, lunes, martes, miércoles y jueves, discutiendo desde diferentes aristas este tema. El día de hoy va a estar con nosotros el profesor Martin Borowski de la Universidad de Heidelberg, a quien pues agradezco realmente su presencia, su disposición con todo este evento. Él también va a estar el día 25 de marzo, el jueves. También va a estar el profesor Arnulfo Mateos, a quien además le quiero agradecer muy profundamente, muy sinceramente, pues la organización de este evento. Realmente gracias a él es que esto es posible, gracias a él es que estamos conectando pues estas experiencias, pero que yo creo sinceramente que son útiles para nuestro país. También quiero agradecer pues, a la Fundación Konrad Adenauer, principalmente a María Christine Fox, por pues también su disposición con este evento. Bueno, más o menos ya saben las dinámicas de nuestros eventos por el Centro de Estudios Constitucionales, donde, bueno, el expositor hace la presentación de sus observaciones sobre el tema y después se abre a discusión o a debate lo que ha dicho. Con nosotros está también Diana González, quien también es una de las organizadoras de este evento. Muchas gracias, Diana, también por toda la preparación para este conversatorio. Diana es investigadora del Centro de Estudios Constitucionales y ella va a estar moderando la sesión de hoy. Diana, pues sin más, te doy la palabra, agradeciendo nuevamente al profesor Borowski por su presencia.
Muchas gracias, de nuevo bienvenidos y bienvenidas a este conversatorio. Y sin mayor preámbulo, solo quisiera decirles a las personas que quieran escuchar este evento en inglés que pueden ir a la página de Twitter del centro y ahí van a encontrar una liga para escuchar la intervención del profesor Borowski en el idioma original en el que va a hablar, es decir, en inglés. Y ya solamente quisiera agradecerle su presencia y dejo la palabra al profesor Borowski. Profesor, muchas gracias por estar con nosotros.
Well, thank you. I am most grateful for the invitation by the Mexican Supreme Court to participate in this seminar, which is devoted to an analysis and evaluation of the German measures against the COVID-19 pandemic, and of course to compare it with measures globally and in Mexico. This webinar is going to run over 4 days with 5 presentations. I will commence the series of lectures today with an overview of the characteristics of the new illness and an overview of the development of the pandemic in Germany. SARS-CoV-2, I should say in English, as the virus is technically called, does not respect borders. It transmits by means of social contact among human beings. Thus, it has developed into a pandemic because it does so successfully. The illness became apparent first in China in January 2020. Most countries have gone through different waves of the pandemic. They were more or less affected and employed more or less effective measures against COVID-19 over time. This is a huge topic In the seminar, we can only aim to give an outline and highlight selected issues. Following my modest introduction into general aspects today, my friend and colleague Carsten Becker from Bayreuth will take up the issue of COVID-19 and the rule of law, broadly speaking, tomorrow. Marie Fuchs from the Konrad Adenauer Foundation is going to address German federalism and its implications on Wednesday. Federalism has been heavily criticized by some in the public debate, owing to the fact that in Germany, many measures are designed and enacted at the state level, not the federal level. Despite the repeated and sustained effort to coordinate measures between the federal level and the state level, in informal rounds with state governors, Ministerpräsidenten, and the federal government, the distribution of competences has led to some inconsistencies between and among different states, and in turn, confusion on the part of the citizens. Why were, at some point in time, DIY stores, do-it-yourself stores, hairdressers' shops, or elementary schools open in one state and closed in the neighboring state, if the virus is actually the same? This perceived absurdity is, of course, not the end of the story of federalism. It is just an opening statement in the legal and political debate on the virtues and vices of federalism in the times of a pandemic. The list of lectures goes on with my lecture on Thursday, in which I try to shed some light on the tension between liberty of the individual and the constitutional obligation to protection granted by the state. I will try to shed some light also on equality in the pandemic too. The final lecture will be held by Daniel Arnolfo Mateos Duran on freedom of assembly during the COVID-19 pandemic in Germany. There were and are demonstrations against COVID-19 countermeasures, namely social distancing and the obligation to wear masks, some organized by rather right-wing associations. On several occasions, the protesters did violate, during their protest, the obligation to social distancing and to wear masks. As already mentioned, the first lecture is trying to lay some groundwork for the following 4 other lectures. I shall begin with the characteristics of SARS-CoV-2 in the illness it causes, COVID-19. One might argue that we know the virus and the illness well enough by now. There are still, however, uncertainties and misperceptions. The latter in part owing to simple and honest lack of knowledge, in part owing to strategic distortion of the truth for political purposes. Our knowledge of the disease has increased considerably over the last 14 months, but there are still important known unknowns. The threat of a pandemic has ever been on the list of threats for humanity. There is one, albeit modest, comfort at the outset of my lecture. It is pretty clear that the COVID-19 pandemic will not be the end of humanity. Apart from that, there is much bad news. Globally, SARS-CoV-2 has killed 2.7 million people by now and infected more than 120 million people. And these are only the numbers as of now and only the reported cases. There is a significant additional estimated number of unreported cases. The measures the pandemic forces upon us to avoid even more deaths and harm will have as their side effects enormous economical costs and social harm. By affecting different parts of the world differently, it may even change the global order for a long time to come. The pandemic, which public health experts and virologists feared most realistically, was pandemic influenza. The swine flu, influenza subtype A, California 7, 2009, H1N1, the swine flu, around 10 years ago seemed to be this feared influenza pandemic. It needs to be recalled that the so-called Spanish flu in 1918 and 19 killed between 20 and 50 million people. And that was actually an earlier influenza A, H1N1, the same subtype. The 2009 version proved, however, far less pathogenic than its earlier relative. The estimated number of deaths for the swine flu lies somewhere between 200,000 and 500,000. Bad enough, but 100 times fewer deaths than the so-called Spanish flu. The fact that until recently the most likely cause for a pandemic was the influenza virus meant that all emergency plans for pandemics were tailored to the characteristics of this virus and the illness it causes, rather than a new coronavirus, and there are important differences. Some coronaviruses, the old coronaviruses, as we may call them, are endemic among humans. They are harmless and cause basically a seasonal cold. A more harmful member of this family emerged 2002 and 2003 in China, called severe acute respiratory syndrome, coronavirus, in short SARS-CoV, or now SARS-CoV-1, because we have two. SARS-CoV-1 infected 8,000 people with a case fatality rate of 11%, and fortunately proved eradicated in humans in 2004. The second appearance of new coronaviruses was the Middle East respiratory syndrome, in short MERS, in 2012. The virus causing this illness is endemic among dromedary camels, hence camel flu. The outbreak from 2012, MERS, was relatively small but protracted. There have been to date around 2,500 cases with a case fatality rate of 35%, mainly in Saudi Arabia and other countries of the Middle East. Overall, the case fatality rate of these two new coronaviruses, 10%, 11%, and 35%, was and is frightening. At any rate, they proved to be no global threat owing to their low infectivity. It is worth emphasizing, however, that virologists perceived new coronaviruses as a significant potential threat and began research to prepare platforms for the development of vaccines. Without that strand of systematic and foundational research on new coronaviruses and their characteristics following SARS-CoV-1 and MERS, the successful and remarkably quick development of effective vaccines against SARS-CoV-2 would not have been possible. Compared to SARS-CoV-1 and MERS, the overall case fatality rate of SARS-CoV-2 makes it look, on first glance, like a relatively harmless family member of the new coronaviruses. Technically, the case fatality rate is the number of confirmed deaths divided by the number of confirmed cases. At the global level, the case fatality rate of SARS-CoV-2 has between 2 and 2.3% in recent months. Note that cases are significantly underreported since there are many asymptomatic cases or mild cases, often mistaken for seasonal cold. On the contrary, deaths are typically reported and, as the case may be, attributed to COVID-19. This is to say that the overall risk of death in case of infection, be it a reported or an unreported case, is very likely around 1%. Considering there are attempts at downplaying COVID-19 as another kind of flu, it should be said that the fatality rate in cases of infection still, for SARS-CoV-2, is still between 10 and 20 times higher compared to seasonal influenza. The alleged comparison between seasonal influenza and COVID-19 has simply no basis in epidemiological numbers. On average, 80% of COVID-19 are mild to moderate. 15% are so severe that hospitalization is suggested or needed, and further 5% are very severe, requiring intensive care, with the most severe cases requiring ventilation or even invasive ventilation. To be sure, these numbers apply to typical populations with a normal mix of age groups and rates of pre-existing conditions. The likelihood of a severe or very severe cause of the disease or death changes dramatically with higher age. There is hardly any other disease for which this phenomenon, higher mortality with higher age, is so pronounced. Thus, countries with older populations are more severely affected. Germany is among these cases, which explains why Germany's case fatality rate has consistently been higher than the world average, despite Germany's relative wealth and a very good health system. For a person infected by SARS-CoV-2, the risk of death in the age group below 44 years is very low, quite similar to the risk of death by seasonal influenza. It is among older people where differences become relevant and eventually dramatic. The risk to die because of SARS-CoV-2 infection in the age group from 45 to 54 rises to 0.2%. In the age group from 55 to 64 to 0.7. For people between 65 and 74, the risk of death in the case of infection is 2.2, which is already 30 times higher compared to the risk of dying from seasonal influenza in the same age group. In the age group from 75 to 84, the risk of death is 7.3%, and it rises further steeply for people above 85 years. Older than 85 years means 30 to 35% risk of death, around 1/3, despite best efforts of doctors to keep patients alive. To express the steep increase of deaths caused by SARS-CoV-2 with higher age from a different angle, in Germany, around 85% of victims of COVID-19 were older than 70 years. So older than 70 years, 85%, below just 15% of deaths. And most of the older ones had pre-existing conditions, and half of them were living in care homes when they became infected. While the overall case fatality rate, or even more the fatality rate in the case of an infection, do not seem dramatic unless you are very old, COVID-19 has characteristics that render it actually very dangerous. To begin with, SARS-CoV-2 has a high reproduction rate, the famous R value. Under the conditions of normal social contacts in modern societies, without any measures against transmission of SARS-CoV-2, such as social distancing and wearing of masks, the R value is estimated to be somewhere between 3 and 5, compared to 1 or 2 for the seasonal influenza. If we take the conservative estimate for COVID-19, this is to say that, on average, every infected person transmits the virus to 3 other persons. This is only the average. Research indicates that a relatively small number of infected people are responsible for the majority of transmissions. Virologists estimate that 10 to 20% of infected people transmit the virus to 80 to 90% of the next generation. So if you take 10 and 80 and assume that we have 10 infected people, only one of them, of those 10, transmits the virus to 24 people in the next generation, that is 80% of 30, 24. And this is the background of the phenomenon of the so-called super spreading events. Typically large indoor gatherings, such as certain church services, sports events, crowded concerts, and the like. And the remaining 9 people are responsible then only for 6 transmissions. So many of them actually do not transmit the virus at all to someone else. This phenomenon of the very uneven rate of transmission is called overdispersion, Überdispersion, which seems to be a characteristic of the whole family of new coronaviruses. SARS-CoV-1 also had this property. This pronounced overdispersion is basically good news, for if you can avoid typical super spreading events, you avoid a great share of the transmissions that would otherwise take place. On the other hand, it is bad news for everyone who is economically or socially dependent on large gatherings in crowded rooms indoors. These potential super spreading events should and will certainly be the last thing to be permitted in the gradual easing of lockdown over time. The high R value of SARS-CoV-2 gives rise to significant exponential growth. The combination of a high case fatality rate with a low level of infectivity, a low R value, is not as bad as it seems on first glance. MERS, with a case fatality rate of 35%, is a good example, for it killed fewer than 900 people in 8 years, while SARS-CoV-2, with its case fatality rate of circa 2%, far lower, has killed 2.7 million people since the beginning of 2020, owing to its very high infectivity. This is the problem, the infectivity. There are other unfortunate characteristics of the infectivity with COVID-19. To begin with, people infected with SARS-CoV-2 are typically infectious up to 2 days before symptoms appear. A person may feel perfectly healthy and may look perfectly healthy. This person can nevertheless infect a great many others in a super spreading event. Second, there are also completely asymptomatic infections with SARS-CoV-2, particularly in children and young adults. Being asymptomatic is very dangerous from an epidemiological point of view, for the infected person may act as an unseen bridge between cases inside clusters or between clusters of cases. What is more, at the outset of the pandemic, transmission was believed to take place primarily by smear infection and by droplets. Smear infection can be avoided by, first of all, washing hands. Infection by droplets by keeping a distance of 1.5 to 2 meters. For droplets fall to ground relatively quickly, even indoors. Unfortunately, it turned out that infection by aerosols, tiny fluid particles, far smaller than droplets, particles that hover in the air, plays the decisive role in transmitting COVID-19. This has enormous practical consequences, for infectious aerosols accumulate over time indoors when infected people are present. This means you can get infected by people in, let's say, a restaurant, sitting as far as 5, 10, or even 20 meters away from you. Countermeasures such as frequent cross-ventilation or air purification are possible, but proved somewhat impractical or technically challenging. For example, many schools in Germany have no automated ventilation system, and effective air purifiers are not available in sufficient quantities. The high R value and exponential growth give rise to an additional problem. The typical case fatality rate of circa 2 to 2.5% over the whole population assumes that every infected person has access to effective treatment in hospital and, if needs be, in intensive care and with ventilation. These 2 to 2.5% are the patients doctors cannot save, even with state-of-the-art medical treatment. If hospitals and intensive care units, ICUs, are overwhelmed, the fatality rate may rise even with a high load of COVID-19 patients inside the intensive care unit capacity to twice as much compared to a low load. And things become even more dramatic if the demand of treatment by COVID-19 patients goes above the formal ICU capacity. Doctors would be forced to take morally and legally very difficult decisions, the so-called triage, to select those who get treatment and a chance to survive, and those who are refused treatment and left to die under morphine. Consequently, the case fatality rate would rise considerably in the overwhelming case. There were some such situations in a few European countries during the first wave in spring 2020. With an eye to hospital overload, Germans remember notorious videos from Italy and New York with lorries full of coffins, leaving hospitals with overflowing morgues. It has become the leitmotif of German measures against the COVID-19 pandemic to avoid the hospitals and intensive care units becoming overwhelmed with patients. Germany has, by comparison, one of the highest numbers of hospital beds and beds in intensive care units per population in Europe, and even more at the global level. At any rate, exponential growth undergirded by a high R value is merciless and quickly outruns even a health system with a very high number of hospital beds. Coming back to the harm COVID-19 causes, until now I have only mentioned the direct mortality caused by the disease. There is also indirect mortality. A health system overwhelmed by a pandemic typically suspends its normal operation with an eye to other health problems. Some non-urgent treatments or checks can be delayed, but there comes a point at which the treatment of serious health problems such as cancer, heart attacks, or strokes is compromised to an extent that a significant number of lives is lost. It seems that this has been, to date, less of the problem in Germany compared to the United Kingdom, where the first and the second wave of COVID-19 has proved as a significant strain on the National Health Service. Beyond direct and indirect mortality, there is morbidity. In mild cases, 80% overall, COVID-19 may seem like a severe cold with fever, dry cough, tiredness, and aches and pains. In severe cases of COVID-19, circa 15%, the patient deteriorates. A week after the onset of symptoms, he develops shortness of breath, indicating pneumonia, and requires hospital treatment typically for 2 to 3 weeks. In the most severe cases, 5%, intensive care is required with a mortality rate between 40 and 60%. Those who survive COVID-19 in intensive care typically have been treated in the hospital for several weeks and often have severe organ damage. They usually need months to recover fully, and it is not clear whether and to what extent there will be lasting damage to the lung, the heart, kidneys, or the brain. Even with a mild cause of the disease, there's the risk of long COVID. Usually, the main symptoms have receded or completely vanished 2 weeks after the onset of the illness. In 10% of infections, there are, however, symptoms persisting for months, with tiredness, shortness of breath, cognitive impairment, and/or cardiac problems. While men have a significantly higher risk for a severe cause of the disease and death compared to women, it seems that women have a higher risk for persisting symptoms. Finally, the risk for a severe cause or death is very low for children and young adults, both male and female. There is, however, the risk of the rare but severe pediatric inflammatory multisystem syndrome, PIMS, P-I-M-S, PIMS. It is severe in the sense that it requires hospitalization and often intensive care and may well prove lethal for children. Lethal if not treated early and consequently enough. and rare is relative with an eye to the high infectivity of SARS-CoV-2 and the enormous number of infected people. In the UK, there were up to 100 cases per week nationally in February 2021. Ethnic minorities in Europe are significantly overrepresented, even more pronounced for PIMS than for infections and severe consequences caused by COVID-19 in Europe in general. They are generally also overrepresented. So this is to say that COVID-19 causes remarkable direct and indirect mortality, significant morbidity, and a great deal of harm to economic wealth and social values. There is a moral and arguably also a legal obligation of the state to prevent or mitigate these harmful consequences. What can be done and what has Germany done? Designing countermeasures is a strictly teleological or consequentialistic undertaking. So understanding the characteristics of the virus and its transmission is key to designing measures against the pandemic. This is why understanding the virus is so important. For example, when people realized that large gatherings often prove to be super spreading events, it was clear that such gatherings cannot be permitted. Social distancing limits social contacts, which is the most basic measure against transmission. Such measures have been in place in Germany in various forms and rigidity from the first lockdown in March 2020 on. Somewhat surprising with hindsight, wearing masks was not regarded particularly effective in Europe in spring 2020, the beginning of the pandemic. There was very limited supply of surgical masks and FFP2 masks, and all supplies were needed in hospitals and care homes. Masks, the population was told, would not protect the person wearing the mask, but might limit transmission to others to a limited extent in the case the wearer of the mask proves infected. Unlike Asians, Europeans would not wear face masks in the case of waves of seasonal influenza, for example. On the very rare occasion to have seen a person with a face mask in Europe before 2020, it was very likely an Asian person. When wearing masks in certain contexts was then later required, masks made from simple fabric, as opposed to surgical masks or FFP2 masks, were permitted and became usual. The first lockdown from March to May 2020 in Germany was not as strict as in other European countries, most notably Italy, Spain, and France. The numbers went down, however, considerably. Travel between member states of the European Union resumed mid-June 2020, and the lockdown was very much eased over the summer 2020. Germany was able to increase the numbers of PCR corona tests quickly compared to other European states and beyond, using an existing network of mainly private labs in the health system. A test and trace strategy was seen as crucial for monitoring and combating the pandemic. By identifying clusters of infections, it would be possible to prevent this cluster from growing and spreading further. This fell in the competence of the Public Health Service as part of the state administration. Gesundheitsämter is the German term. The typical modes of operation of this administrative service, contacting people by letter or telephone and communicating by telefax, were rather outdated, rendering contact tracing slow. Reasonable efforts were undertaken to speed up the service's work. Manual contact tracing remained, however, still cumbersome and slow. It has been another leitmotif of Germany's COVID-19 policy to keep the rate of infections per week and per 100,000 people below 50. 1 week, 7 days, 100,000 people, and then 50 infections. Because otherwise the Gesundheitsämter would become overwhelmed with contact tracing, so that transmissions would become diffuse and uncontrolled. Note that this also guarantees that hospitals are not overwhelmed with COVID-19 patients, the other leitmotif. Admittedly, the characteristics of the disease, the generational span of 5 to 6 days, and the fact of being infectious 2 days prior to developing symptoms, there is actually not enough time for manual contact tracing. A digitalized system of contact tracing could, of course, be far quicker, easily overtaking the spread of the virus. There is, however, strong emphasis on data protection in Europe and particularly in Germany. Very effective digitalized systems of contact tracing, such as those used in East Asia, interfere severely with data protection and were out of question for Germans from the outset. In my view, considering the impressive success of combating COVID-19 in Asian countries, such effective systems should be considered with less hesitation, not copied one by one, but considered. The result of insisting on stringent data protection is the German so-called Corona app for Android and iOS that, to be short, provides perfect data protection, but proves rather useless for contact tracing by the Gesundheitsämter. The whole system depends on the voluntary input of the user in case he tests positively for COVID-19, so that the system then sends an anonymous warning to all those people with which the user came into close contact for a dangerous amount of time in the period in which he is retroactively considered being infectious. Unfortunately, anonymous surveys suggest that only 60% of those who use this German Corona app actually inform the system of their positive test. The other 40% obviously prefer to be warned by others, but not to warn others themselves. It is, of course, tempting to criticize this Corona app. There is, however, a dilemma. If the Corona app provides much data protection, its effectiveness must be limited. If it provided much less data protection, far fewer people would use it. Its use is voluntary, and making its use a legal obligation meets with practical difficulty and a widespread conviction that this would be unconstitutional. Despite the issues mentioned above, the first wave of COVID-19 cases from March to May 2020, with a peak of around 7,000 daily infections, 82 million people in Germany, 7,000 daily infections, was overcome. From the end of May to the end of August, daily cases remained below 1,000, often considerably lower. There was a modest increase to an average of 2,000 weekly peak cases in September, still well below the peak of the first wave. And people were expecting, to a certain extent, an increase in the autumn, when many social activities move indoors in Europe owing to the colder weather. Unfortunately, despite clear warnings of virologists, the German public and German politicians had become complacent. Most people were thinking that Germany had a fantastic health system, fantastic PCR testing, and a decent test and trace system, and social distancing brought everything under control in the spring. Many thought that we had everything under control and needed no lessons from other countries. The public was genuinely shocked by the steep increase that followed in November and October-November 2020, just as virologists had actually warned, owing to the phenomenon of percolation, the pandemic flared up heavily, immediately everywhere. This is something they predicted. So in November, there were up to 20,000 daily cases, peak in a week, and in December, up to 30,000 cases per day. And this is to say that the peak of the second wave was more than four times higher than the peak of the first wave. The first wave had a peak of 300 daily deaths in Germany. The second wave went well beyond 1,000 deaths every day. While Germany compared favorably to European neighbors during the first wave, it looked far less impressive in the second European wave. This second wave required, of course, a second lockdown in Germany, and this winter lockdown brought the number of cases down, although it proved less effective than the first wave. And the main reason for that is emotional rather than rational. Many Germans, at least a significant minority, are simply fed up with being limited by lockdown measures. They want unconcerned holidays in their preferred destinations. They want to go to the restaurant or to the pub. They want to go to concerts or to the museum and simply want to go shopping into the city. In short, they want everything that has been forbidden from November 2020 on. Particular point of contention was keeping kindergartens and schools open. There was a protracted debate as to whether children contract and transmit the disease. What should be a scientific debate had strong political overtones. Virologists who claimed that transmission at school is possible, which indeed it is, and indeed likely, received series of death threats. Despite the strong wish for ending or at least significantly easing the lockdown by many Germans, the outlook is bleak. Infections dropped to a weekly peak around 10,000 back in February, when a modest easing of some aspects of the lockdown was agreed. To be sure, numbers are still higher than the peak of the first wave, and cases have begun to rise to nearly twice that level recently. And even worse is that this increase, the recent increase, is still accelerating. Why so? The recent increase in infections has little, if any, to do with a change in measures against COVID-19 or a changed behavior in the public. It is very likely brought about by the fact that the classic variant of SARS-CoV-2 has been largely replaced by the mutant strain B117, colloquially called the British mutant. For it appeared first in Southwest England and London. There is actually a whole class of so-called variants of concern. The most important other mutants are the Brazilian variant, P1, and the South African variant, B1351. While in Germany, the British mutant was unknown 3 months ago, as recent as 3 months ago. Now, 75% of all COVID-19 cases are caused by this variant. In London, this mutant, the British mutant, has nearly completely eradicated the classic variant, and the development in Germany points in the very same direction. Epidemiological data suggests that the British mutant is significantly more infectious than the classic variant. Recent studies from the UK and Denmark suggest a 60% higher transmissibility. If you recall from the first part of this lecture, it is precisely the high infectivity of SARS-CoV-2 that makes COVID-19 so dangerous. So this is really bad news. And contrary to initial assumptions, the British mutant also causes higher mortality and morbidity, also increased by around 60%. The only good news is that immunity following an infection with the classic variant of COVID-19 or following vaccination with the vaccines we already have, both seem to be effective against the British mutant. This may be different for the South African variant, but this variant has not yet spread significantly to Germany or in Germany. And one has to say these three variants of concern are the results of an optimization process that SARS-CoV-2 undergoes, and this optimization process will go on. And this brings me to new measures against COVID-19. First is quick tests that give a result about an infection in 15 to 30 minutes. Unlike PCR tests, which are more reliable but need to be processed in a lab, quick tests can be used for entry testing in care homes, or weekly tests in schools, to name only two contexts in which they may prove helpful. Quick tests will be shortly available in sufficient quantities and qualities. They may prove helpful for bringing numbers down, although they are not the game-changing element. Initial hopes that medical drugs would be found to treat patients infected with SARS-CoV-2 have sadly washed out. Some drugs proved somewhat helpful for this or that subgroup of patients. There has not been, however, any real breakthrough. The biggest promise, and my last topic, for effectively ending the pandemic is vaccination. As recently in autumn 2020, many experts on vaccination were pessimistic as to whether an effective vaccination against COVID-19 would ever be developed, and if so, how many years this might take. Considering that there are well-known viruses against which no vaccine has been found, and that developing a vaccine usually takes 2 to 5 years in the lab, and additional 5 to 8 years of clinical testing, it is nothing short of a miracle that we already have, 15 months after the outbreak of the pandemic, no fewer than 4 licensed vaccines, which have already proven very effective and, as far as we can say, safe. The challenge at the global level is, however, to produce enough vaccines quickly enough. Even though the first licensed vaccine, BioNTech Pfizer, was developed in Germany, this does not mean that Germany has a sufficient supply of this vaccine. At the global level, there is pronounced vaccine nationalism. The United States follow, even under the Biden administration, the policy America first. And by this, they mean their country, not the continent. Exporting vaccines or pre-products for vaccines is prohibited unless they have sufficient supply for their country. The UK, United Kingdom, has received quite some vaccines from the EU, companies in the EU, but as a matter of fact, no vaccines were and are exported from the UK to the EU. AstraZeneca's policy of honoring contractual obligations towards the UK and the EU differently has proved, let us say politely, difficult to understand. Currently, the tensions are escalating, and we may find ourselves in the middle of what we might call a vaccine war. While the US and the UK are acting rather successfully as individual states and have high vaccination rates already, the decision was taken in Germany and in the EU generally to procure vaccines for the whole of the EU on a solidarical basis. The European Commission's efforts to buy vaccines are regarded as rather slow and less successful, which may be unfair, but this is the public perception in Germany. To put it bluntly, many Germans think that Germany alone would have been far more successful, which delegitimizes the EU to a certain extent in German eyes. What is more, the German government is blamed at least indirectly for letting the shortage of vaccines happen. The government assured that the vaccination campaign will gain much momentum from April on. Angela Merkel promised every German adult the offer of a vaccination until the end of the summer, namely 21st September 2021. Considering the steep increase, the steep second wave in November 2020, the second wave, the British mutant and possibly new variants of concern, another winter wave at the end of 2021 without a fully vaccinated public would very likely prove disastrous. First of all, however, a third wave is rolling on for April and May now, and we have to get over this without much effects from vaccination. To conclude, I hope that my remarks gave you an idea where we were and are in Germany with an eye to the COVID-19 pandemic, and I am, of course, happy to answer your questions to the best of my knowledge. Thank you very much for your kind attention. Thank you.
Muchísimas gracias por su presentación, profesor Borowski. Tenemos muchísimas personas viendo este evento y la cantidad de preguntas es verdaderamente abrumador. Entonces, lo que yo voy a hacer es reunir estas preguntas en ciertas categorías e intentar hacer la mayor cantidad. Hay una preocupación recurrente sobre la desigualdad en distribución de vacunas, tanto a nivel global como dentro de los países. Entonces, la pregunta es, ¿cuál sería la relación o los efectos en términos de derechos fundamentales de la desigualdad entre países de distribución de vacunas, ¿no? Que los países más ricos tengan la posibilidad de vacunar a su gente mucho más rápido que los países pobres, y dentro de los países, si la desigualdad impacta de alguna manera la distribución y la aplicación de estas vacunas. Esa es como una primera categoría de preguntas. Hola.
I'm afraid I did not get a translation if this was a question addressed to me.
Okay.
Okay.
Are you listening to now?
I activated English now. I found it. My fault. Apologies. Could you just be so kind for me, because the translation is gone now. Could you repeat the question for me so that the translator translates it again? Apology. Yeah.
Sí, hay una preocupación generalizada grande en relación con la desigualdad en distribución de las vacunas a nivel global. Entonces hay una pregunta general sobre cuál puede ser la relación entre el derecho fundamental a la salud y la distribución inequitativa de vacunas a nivel global. Y la segunda es una preocupación por el impacto de la desigualdad dentro de los países, especialmente en México y Alemania. Pero pues la pregunta sería en este contexto más hacia Alemania. ¿Qué impacto ha tenido las desigualdades económicas y sociales en Alemania, la enfermedad, el virus, y específicamente si hay alguna relación entre distribución de vacunas y desigualdad económica y social en el contexto alemán?
Well, thank you. Now I get the translation, and I think problems should be sorted completely. Now, I agree completely with you that there is a issue of distributive justice at the global level. And you can approach this issue from two different angles. You can approach the angle from just observing what happens. So this is basically observing what factually happens. And I touched slightly this topic when I mentioned the US and the United Kingdom. And the European Union may actually not be much better because we are now, so to speak, comparing the European Union to the US. We are somewhat complaining about the US, that the US does not send vaccines to Germany. But of course, this is a very limited perspective. And as a matter of fact, the big companies producing vaccines are typically located in economically wealthy countries. And governments, just as a matter of fact, made sure that they receive the vaccines first. Why? Because politically, they are first and foremost democratically responsible to their own public. And those are the people who are going to elect the next government, which is, of course, they think that what should happen. And I can also reveal to you, when I said that Angela Merkel made the promise that every German receives a vaccine offer until 21st of September 2021, one should know that actually on the 26th of September of 2021, there is the next federal election in Germany, which is every 5 years. So the hard, just as an observation, the hard truth is that elected governments feel responsibility first and foremost to the demos that legitimizes them. And then the international obligations, in some sense, come second. And this is an observation. Now, this is, of course, not the only angle to approach this. There is the normative angle, and that is where the distributive justice requires that wealthier states, wealthier in terms of vaccines, share, at least to a certain extent, their vaccine wealth with countries who are not as wealthy in terms of vaccines. And we are here in the world of international law and conventions and pacts in international law, which, as we all know, are not as easily enforceable just as constitutional rights in the national context. This is not my main topic, but of course I'm happy to make a couple of remarks on that. But this is definitely a specific topic that will be addressed over the next months and years. And of course, it is good in Europe if you have this European context because it kind of this automatic and understood nationalism, which is, I think, for old and successful member states just an automatism, is kind of placed in perspective if you're a member state of the European Union, because when the decision of the German government to go European, so to speak, with the vaccine procurement was criticized, there were many voices, interestingly, that said, look, guys, they said, look, imagine you have a German which is 25, very low risk of death and severe illness, and the 25-year-old German has already been vaccinated. And you have an 87-year-old Greece farmer who dies of the disease, who would have a good chance to survive this, although the 25-year-old German young adult actually did not really need this vaccination. So this is seen as a problem of injustice. And then once you have, so to speak, broken up this automatic nationalism, I think people are much more susceptible to the even broader point of comparison that is beyond the European level, the global level. And we will see many contributions on that. Inside countries, yeah, this is an interesting point. In vaccination, well, we don't have that many vaccines, but we have some. We are expecting more from April on. Now, you can't buy vaccine in Germany. It's not on the market. Only the German state, the federal state, buys the vaccines. The federal state has contracts with the big companies. You can't buy it in a pharmacy or so, or on the internet. There may be a black market, I don't know, but there hasn't much been debate about that. And in Germany, actually, I tend to doubt it, that there is really a black market from the vaccines the German government buys. Then the federal level buys the vaccines. The states organize the vaccination technically. So they set up the vaccination centers, they organize the whole thing. And there is a list, a vaccine priority, and it's very strictly age. Germany is now vaccinating people over 80. And some people who are working in hospitals, in care homes, where because of the social contacts they have with old people, would make them very dangerous for transmitting the disease. So there's this element too, but mainly this is vaccination by age. And you can't buy a vaccine, not even for thousands of euros or tens of thousands of euros. It's not possible to buy a vaccine. So this is strictly regulated by the federal government. Now, this is vaccination. When it comes to to consequences of COVID-19 infections, well, the economic wealth may, of course, well have some repercussions for the risk of getting infected. If you live in crowded housing, if you are forced by occupation, if you are forced to have many social contacts, the likelihood that you get infected is higher. And this has also some background element, so to speak, in economic wealth. But this is not a very pronounced inequality. There is a third topic which springs to mind. I touched upon this in the lecture very briefly when I was talking about this children infection syndrome. People with migrant background are much overrepresented, significantly overrepresented, even in terms of severe cause of illness. And there hasn't been much public debate about that, which may be a good thing or a bad thing. It's difficult to say. There hasn't been much debate, and we don't know what the causes for this uneven distributions of infections and even severe infections may be. It may be that information is owing to language barriers, is not really going out to them. So prevention doesn't really work for them. It may be that there are other factors at work, but I would have to speculate, and this would be an invitation for people to spring on that and do things with it that I'm not happy with. Inside countries, and it's basically inside the country, it's up to the state in question to organize some kind of distributive system. I think in Germany it's very clear and it's followed. So, but it may be different in other countries.
Muchas gracias. El siguiente conjunto de preguntas está vinculada con el problema de las vacunas también, ¿no? Y cómo está funcionando en Alemania. El primero es que, como usted habló un poco de eso en su presentación, pero el público está pidiendo que abunde sobre eso, y es ¿qué pasa con este grupo de personas que son antivacunas? ¿No? Sí, ¿qué tipo de esquema de vacunación tiene Alemania? Si es un esquema de vacunación obligatoria, ¿no? En general, y si se ha pensado en un esquema de vacunación específico, ¿no? Las obligaciones para la población en relación con la vacuna contra el COVID. Entonces, la pregunta es por las tensiones que hay entre el derecho a la libertad y la autodeterminación de las personas para decidir si se ponen o no la vacuna y los riesgos de salud pública que eso implica. ¿Cuál ha sido la posición de Alemania en relación con eso? El segundo grupo de preguntas es acerca del pasaporte COVID, ¿no? Parece que hay una iniciativa, o está sonando al menos, que los países van a empezar a pedir en sus fronteras un pasaporte COVID de las personas vacunadas y no vacunadas. Entonces, ¿cuál puede ser el impacto de este pasaporte en términos de desigualdad entre países y los efectos además para las personas migrantes al interior de los países? Y el tercer grupo de preguntas está vinculadas con el problema de la transparencia y los contratos para adquirir vacunas. Un componente importante del derecho fundamental a la salud es el consentimiento informado, ¿no? Poder tomar decisiones con base en información suficiente. Y muchos gobiernos, no sabemos cuál es el caso de Alemania, han blindado los contratos de compra de vacunas, ¿no? Como información protegida. Entonces, la pregunta es si esta decisión de blindar los contratos de compra de vacunas puede ser violatoria del derecho a la salud en su modalidad de derecho a acceso a la información, consentimiento informado, y cuál ha sido la aproximación de Alemania a este tópico en particular. Entonces, es una pregunta algo extensa y diversa, pero muy recurrente.
Well, thank you. This is really getting up to speed. So thank you for these interesting and valuable questions. I tried to be comprehensive but brief. First, vaccination. How does vaccination work in Germany? It is voluntary. There's no obligation to receive a vaccination. Of course, the background is if you want to achieve herd immunity, if you want to achieve a degree of vaccination that is sufficient so that the pandemic is not spreading any further, and the variants of concern, because the reproduction rate is higher, probably set the threshold for herd immunity higher also, which is bad news. You want basically to come up with herd immunity. I think the German approach to that topic is, as far as I understand, political in the sense that they have decided not to antagonize people with talking too much about obligatory vaccination and so on. They just say, we buy the vaccines, it's free, you can register. If it's your turn in terms of priorities, you can register, you get the vaccine for free. You don't have to, you can stay at home. And it's perfectly fine. Now, and I think Germany has decided politically, my speculation, has decided politically just to wait and see. And if already 50%, 60% have been vaccinated and they are still alive, they are looking up and running and no dramatic things have happened, even more people may just decide voluntarily to take up the vaccine. Now, if at some point in August, September, or whenever comes and politicians realize, well, there is a problem. There is a problem and we don't achieve herd immunity, then the discussion will begin anew. And then it's, well, we have to make a second seminar and have to comment on what will be happening then. But it looks now, I think polls now say that 72% of Germans, of adult Germans, are happy to receive the vaccine. And I think this comes very close to what would be herd immunity. So it may simply work with this voluntary decision. Now, just a short remark. This is a huge topic. Just a short remark. There could be something which I shall term an indirect obligation. And the indirect obligation means you get more freedom if you are vaccinated. So you can go to the restaurant if you are vaccinated. You can go to the concert if you are vaccinated. You can go on holiday to the popular destinations if you are vaccinated. If not, not. Now, this would be an indirect push, and probably politicians would prefer that to a direct obligation, because vaccination can have, very rarely, but can have harmful consequences, even deadly. So keeping it voluntary has always been a leitmotif up to now. And so there's no problem as of yet with the right to free determination, because no one is forced to take the vaccine. You simply stay at home, you say, I don't do it, I wait and see what happens to the others, and maybe at a later point, I come forward, get my vaccination or not. It's still completely free. Now, the COVID-19 passport is an interesting thing, because as far as I'm aware, the COVID-19 passport, there's now an initiative from the European Commission. And of course, you would not establish a COVID-19 passport unless you do not want to do anything with it. So if you invent such a thing, you obviously want to do something with it. Now, what they want to do with it is not something they have openly said. I don't think that there's a very clear kind of vicious secret plan. It is just that they realize they need something like that, because in the case member states decide, because there are still many national competences in the European Union, if member states decide, for example, if Germany says our citizens should have the possibility to go to Spain for holiday. And if Spain is happy to receive Germans for holiday in certain circumstances. Now, if the whole thing or some aspects of it depend on being vaccinated, there should be some kind of centralized system to determine who actually has been vaccinated, maybe even with which vaccine, because they may prove different. And so there has to be a standard solution, because otherwise, if people running around with sheets of papers, you get all these fraudulent versions from the internet for $5 or so, and it doesn't work. So it's the idea to establish a system, but what the system really is supposed to permit in terms of substantive freedoms, what can you do with it? This has not been decided yet. Well, what influence might this have on migrant populations? Well, as long as COVID-19 vaccines are distributed in a non-discriminatory manner, so if it's just age, if you just come forward as a legal resident in the right age bracket, you don't have to be a national, you just have to be a legal resident. You get the vaccination, that's perfectly fine. Things become tricky, of course, if you're an illegal resident and fall in the age bracket, because you then have a problem. But thank you for inviting my attention to that problem, because this is something I think needs to be taken into consideration. Although I should have to say that Germany has a very stringent system of registering citizens where they live. So I don't think that we have that many. There are, of course, some people who are illegally here, but it's not a huge problem. There are not millions and millions of people here. There's an issue. But of course, if they are not vaccinated, they may prove not a harm. It's not harmful for themselves if they get COVID. They may transmit COVID. So there is actually an incentive for the German health system to make sure they are vaccinated, even if they are not documented. But this is a good question. I will think about that. And secret contracts. Interesting questions about contracts. Because the vaccine contracts were concluded by the European Union, Germany has actually not agreed contracts themselves. So Germany did not agree contracts, it's the European Union. But the same problem, of course, applies at a higher level. Now, the companies who sell the vaccines usually insist on the secrecy of the contract. And first and foremost, because the prices that different countries had to pay were different. Which we don't know because all contracts are secret, but people assume that the European Union negotiated relatively hard and actually did not pay high prices for vaccines, while the US and the UK were very eager to get as much vaccines as early as possible, and they probably agreed higher prices. So the companies have a kind of interest that their customers, so to speak, do not compare the prices they pay. Although it's not a secrecy, the European Union paid for the BioNTech Pfizer vaccine, it's around $15 per shot, per vaccine shot. You need 2 shots per person, so this is $30 for Pfizer BioNTech. They work for profit. AstraZeneca is a not-for-profit. This is around $2 per shot. It's far cheaper, and AstraZeneca had the policy of developing this. Now, and this, of course, has to do with vaccine, the first question, global inequality. If it's cheaper, and if it's actually the price AstraZeneca basically themselves have to pay to produce the thing, and they sell it for $2, it's, of course, in terms of global distribution, far better than the for-profit Pfizer-BioNTech vaccine. Now, the question is this a problem of informed consent? I don't think so, to be honest. Informed consent, in the case you get a vaccine for free. In Germany, remember, you don't pay anything. You get a vaccine for free. Now, for informed consent, it is relevant what the vaccine is, how effective it is, what kind of side effects it has, and there needs to be clarity and transparency to the properties of the vaccine. Now, if you know that, you can decide, I want it or I don't want it. Frankly, what your government paid, or the European Union on behalf of all governments actually paid to the company for that vaccine, doesn't strike me actually as a crucial point for informed consent, because I get it for free. It may be that as a, so to speak, a broader overarching imperative, there should be transparency on how governments approach these things. Yes, but for the person who receives the vaccine, it is only relevant what it is, whether it's effective, whether it's safe, whether one knows what one signs up to when one accepts to receive it. But apart from that, I think whether it costs 12 euros or 14 or 7 isn't that much of a problem. It's a general transparency problem, but not for the person, for the people receiving it. And well, the European Union actually put significant parts of the contract with AstraZeneca on a Commission website. Just for a couple of minutes, of course, it was taken down very quickly, but you know the internet, yeah, people, and it was done. Well, I don't know. I shouldn't speculate, but I would be surprised if this was just a simple mistake. It was, I think, probably had a political overtone to do that. So they are not happy with that themselves. But thank you for these good questions.
El siguiente grupo de preguntas está preocupado por el derecho a la educación de los niños en el contexto, el derecho a la educación en general en el contexto de la pandemia. Usted se refirió un poco a ello en su presentación en relación con los desafíos para el federalismo de las decisiones sobre si abrir o no abrir escuelas. Entonces, la pregunta general es, ¿cuál ha sido la aproximación, si puede abundar en cuál ha sido la aproximación del gobierno federal y de los estados a este problema de la apertura o no de las escuelas? Y en segundo lugar, ¿cuáles son, qué considera usted que debe tomarse en cuenta en estos casos, ¿no? Si el que vayan los niños al colegio, por ejemplo, puede hacer que la enfermedad, el virus, se propague más rápidamente, si el mantener cerrados los colegios puede generar problemas con el derecho al acceso a la educación, ¿no? Sobre todo de los niños de los niños en general, pero sobre todo de los más vulnerables. Entonces, esa es la pregunta. Por un lado, la tensión con el federalismo, y en segundo lugar, la tensión con el derecho a la educación.
Yeah, thank you. This is really one of the most debated issues in Germany. And let me emphasize from the outset of my answer that what we really need is clear, sound, and solid scientific data. This is the most crucial thing, because if we want to evaluate the different interests at stake here in this problem, we need to know what is really going on. And this is a problem because, well, in the era, fortunately, after Trump and his style of doing political debates, we went through an era of fake news, and the hesitation just to claim falsehoods for truth. The hesitation has gone down, and people, unfortunately, are relatively easily saying, so those who have a vested interest that the schools are opened, they tend to say there are no data available that actually transmissions can happen at school, which is not true. this is why we need solid data. And this is the most important thing. There are such studies out there. It was from the outset, there was the belief that children would not get infected because children typically do not show symptoms. But it proved that at least some part of this phenomenon can be attributed to the fact that children actually get infected, but remain asymptomatic. And now this is good for the children because they don't feel sick. They are well. But of course, it is very dangerous because when they visit their grandfather and their grandmother at the weekend outside the city, and they go there with their parents, and they are infected, they may transmit the virus to their grandfather and their grandmother. They may get infected and then consequently possibly die. So we need data. And because this is politically so controversial, there was so much pressure on the virologists to say that this is the case or is not the case. So there was really pressure on the fact-finding side of that problem. And if we know that for the classic variant of COVID-19, this may already be outdated because we now have 75% and more of the British mutant. And it is claimed, we don't know, we need sound and solid data, but it is claimed that the higher infectivity of the British variant is even more pronounced in the school setting. And this is epidemiological data from the UK, where the British mutant was coming from and where the schools were open at some point. Now, these sets of data are not easy to interpret because you need to look at all the circumstances and take them into consideration when interpreting the whole thing. So we need a sound and solid debate. Opening schools was considered important. And of course, the right of education to children plays a role. And it has always been said in the German debate that the inequality between wealthy children and less wealthy children, of course, gets more pronounced when there is not when the schools are not open. What happens if schools are not open? If you are a child from a poor family, you sit then in a relatively crowded housing, probably. You do not have your own computer. If you try to do some work in this crowded room, there's noise. Siblings are watching TV, mother is cooking, something's going on. While if you're a wealthy child, you have your own separate room. You have a precious computer, the latest model, a fancy thing standing there just waiting for you. It's quiet and you can learn. So while at school, everyone is sitting in the same type of benches with the same kind of books. So the education at school, when schools are open, is more equal, and it creates more equality and more equal opportunities. And this is a cost. This is definitely a cost. The social cost of rising inequality and the cost of interference with the right to education of children. German teachers tend to say now that the year 2020 is basically lost because the schools were closed for such a long time that the gaps that have emerged cannot be closed just on the side with the next year at school, but the children actually are risking to lose the whole year, thereby losing 1 year time before they finish their education and so on, with all the consequential postponements of all later stages in life. Well, what should we take into account? Well, everything, the interests of the children. In the political debate, I'm not always so sure when politicians say we are concerned about the right of education for children, because the political pressure on the politicians is from parents. And parents of course, have an interest that their child is treated fairly and receives the best education, but parents also kind of tend to get fed up if their child stays at home all the time. And they have to take care, they have to make sure that homeworks are done, they have to go with them through mathematics, through Latin, through Spanish, or whatever they learn at school. So there's also, I think the political pressure is from the parents on behalf of their children, but to some extent also on their own behalf to keep the schools open. But as said, if there is a significant danger, and if the British mutant actually, if it proves to be much more infectious among children, and they bring the infections from school back to home, there is a problem. And so you have to, at least now in April and May, before vaccination has really an effect on the infectivity in the public, there may be a problem. We have to close schools again. It's actually, as we speak, the state governors and Angela Merkel and her federal ministers are sitting together with the next round, decision of next rounds, what the measures will be up to mid-April. And I suspect very much, I haven't looked at the news while I was doing the Zoom thing here with you, this would be respectless, not doing that, but I would be surprised if they do not announce at least school closures for April and May. And you just have to balance, and if you, on the balance of everything, come to the conclusion that the risk of infections is simply too high, then there's nothing else you can do. The only thing for us to do is vaccination, vaccination, vaccination. This will get us out of the whole thing. If the adults are vaccinated, the children can go to school, and probably not much will happen. If you vaccinate children because of PIMS is a completely different question, and not our question now, because there's no vaccine actually licensed for children. And I don't know whether it's a good idea. Maybe PIMS is not a justification enough to risk vaccines for children who have 70 to 80 years of life before them, and 80 years of life to develop side effects, which is a horrible way to think of. But on the balance, it is a serious problem, but there may be no other choice than closing schools. But we need data, 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 data.
Muy bien. El siguiente grupo de preguntas está vinculada con los desafíos, de nuevo, del derecho a la salud que ha enfrentado Alemania en relación con dos tópicos especiales. El primero de ellos son los desafíos en bioética. ¿Sí? Usted ya nos dijo que se tiene la impresión, y no solo la impresión, sino que es así, que el sistema de salud alemán es muy sólido, ¿no? Y es relativamente equitativo. Entonces, las preguntas son, ¿cómo ha enfrentado un sistema de salud que tiene recursos escasos, pero no los problemas de recursos escasos que tienen otro tipo de otros países? Problemas de bioética, de priorización, ¿no? De a quién se atiende primero según sus características en situaciones cuando llegan con el virus, ¿no? En situaciones que necesitan hospitalización, o simplemente la decisión de quiénes se hospitalizan y quiénes no. Entonces, ¿cómo se ranquean, digamos, estas personas con infecciones? Y en relación también con algo de lo que usted habló, y son las enfermedades crónicas que necesitan atención hospitalaria, pero que se han visto desplazadas, ¿no? En razón de la necesidad de atender el COVID por parte de las instituciones de salud. Entonces, esa es una, ¿no? Bioética, priorización, y qué desafíos implica esa priorización. Y la segunda es, ¿cuál es el acercamiento del Estado alemán hacia los problemas de salud mental que puede estar enfrentando su población, ¿no? Y de problemas de salud mental diferenciado por edades, por situaciones socioeconómicas, por condición de género, y si hay algunos datos sobre cuál ha sido el impacto.
Leyendo los transitorios, bueno, una reforma al juicio ejecutivo mercantil, bueno, toda la parte mercantil.
¿Cuál ha sido el impacto de la pandemia sobre cuestiones de género en específico, ¿no?
Yeah, thank you. The right to health, bioethical changes. The question was phrased, and it was said that patients are generally treated based on their needs. I'm not sure that I get the thrust of the question well, but it. Yeah, but what challenges? What means bioethical?
En cuestiones de priorización, dice la pregunta. Entonces, si tenemos a una persona de 80 años con buena salud frente a una persona con una salud pobre de 17 años y llegan a solicitar el servicio, ¿no? ¿Cómo se prioriza en un estado que no tiene los desafíos de recursos escasos como los tienen otros países? Y si es cierto, en primer lugar, que eso es así, que enfrentan menos desafíos los sistemas de salud sólidos como el alemán en relación con este tipo de ranqueo, ¿no?
Okay. Yeah, thank you. I think I get the question now better. Thank you very much for this additional explanation. The German health system is basically a two-tier system. There is the general state health system, which is not like the NHS, so to speak, completely run by the state, but it's very much organized by the state. And it has an element of solidarity in the sense that the fee you pay for getting insured depends on what you earn. So people who earn much money pay much. People who earn little or no money pay very little, if any. And people who earn in the medium bracket have a kind of medium fee. Now, irrespective of what you pay, you get the same treatment. So you can't say, I actually earn so much money, I paid this concrete fee to you, and I have priority because over these people, because they are poor, insured for free by the state. This argument doesn't work. And so this is based on solidarity. There is the second layer, which is the private health system, which does not have this element of solidarity. Now, the service that you get is basically the same for the people who are privately insured. They have some benefits. They get an appointment earlier often. There are some aspects for which the doctors get more money. But when it comes to serious problems, when it comes to cancer, for example, to stroke, to heart attacks and the like, the service you get from the state system and the private system is very much the same, So there's quite some equality here at stake. The standard you get from this kind of compulsory state system is compared to these compulsory basic systems at the global level. The German level is very high. And so the need to prioritize is not so much there, because there is a very decent standard level of medical care. And this is, I often have foreign guests, some of them even for months or for 1 or 2 years, and they are then insured as foreigners who are legally resident here in this system. And they are often surprised They say this is amazing. I have to pay hardly anything, and I get basically everything. It's a bit overstated because of national pride. Forgive me that. But so the standard is relatively high. So being economically poor would not make a difference in being entitled to this very standard, very decent standard international of health system. I think this is something Germany does very well. The problem is, this is not now a problem for the individual. The problem is that Germany's health system may not be very effective. We may pay very much for getting much. And we would be fine if you pay very much to get very much, or if you get only much to pay much, but not very much. So the efficiencies in the systems may not be impressive, but the standard for the individual user at the point of service is relatively good. And so, of course, well, there are some doctors, if you are going for plastic surgery, if you don't like your nose or something like that, of course, this will not be paid by this standard. It's actually for illnesses, not for something luxurious. So you will not get this. And if you want the world leading surgeon for your surgery, you may actually pay someone who then does it. And if you're a millionaire or billionaire, of course, there you will find doctors who do things outside these kind of standard systems of care. But the standard systems of care are very decent, and very many people use those. So there's not a big industry. You don't say, well, this state system is for the poor people, and this is not impressive. We have our own system as rich people. Basically, everyone uses it. With chronic diseases, this is also, in some sense, the answer to the second question is the same as for the first question. Because Germany has many hospital beds, fortunately, even during the second wave of COVID-19, the capacity of intensive care units was only required up to 30% of ICU capacity. Only 30% of ICU beds were filled with COVID-19 patients, which is to say that 70% or kind of 60, you hardly ever have 100% use of ICU beds, but 60% was still there for heart attacks, for cancer problems, and other. So the impact in Germany on standard care, for example, cancer surgeries, have, as far as I know, never been halted in Germany. If you needed a cancer surgery, if cancer was detected, they said there's something, it needs to go out now. You basically had a surgery 2 or 3 days later. So this was still basically possible. The problem with COVID-19 patients on the ICU beds is that this is not so much a strain on the bed, on the number of beds, it's more much a strain on the personnel, on the staff, because the COVID-19 patients in intensive care require very much attention and very much surveillance. So the bottleneck is not the number of beds, it's actually qualified staff to take care of those people. So I would like to think that in Germany, no serious harm of this indirect consequence has of yet happened. We know from other countries, anecdotally, I mentioned the United Kingdom, they stopped cancer care. They stopped giving chemotherapies to people out there because it suppresses your immune system. If you get COVID-19 with the chemotherapy, that's a very high risk of you dying. So they stopped these things because they had no capacity. And there are many other countries. It's not only Germany and the UK, of course. I lived there for 6 years. So this is kind of my point in comparison. That was inside Europe, but now owing to Brexit is outside Europe, as we all know. So I don't think there were many problems in Germany as of yet, but this could come. If a third wave, a fourth wave, like a tsunami comes in, these things will happen. We have seen it in other countries. Mental health issues. Well, yeah, there's no surprise here. Social contacts stabilize people. if you don't have social contacts, if you are isolated, if people tell you don't go out, don't speak to people, they make you sick, you will die, basically. You stay at home and you don't have the psychologically stabilizing effect of social contacts. And so mental suffering, mental health issues that are there grow. People who are on the border of having mental health issues are pushed over the border and now have some mental health issues. There is a problem. I don't have solid data, but this is mentioned in many reports anecdotally, that people working in psychology, psychiatrists, and the like report that there is actually there is a problem, and numbers are significantly growing. Gender inequality. Well, no surprise, I'm afraid, here. The perception is if schools are closed and the mother is working, the father is working, and now the children are at home and someone has to check the homework and go through some lessons in geography or whatever. There's no legal norm, there is no constitutional expectation or whatever, but as a matter of fact, it is most often the women who do both, who go to work, and once they have come home from work, they do the homework and they do the children's homework with the children. So this is the perception, far being from a justification, of course. But if you have a traditional distribution of roles in the family and taking care of children while they would usually be at school, typically then in the general perception falls more into the competence and indeed responsibility, or women may feel more often responsible for that. So in fact, it was described as a particular setback in terms of equality measures, because the burden of women has just on average proved to be higher. Now, the question, of course, is what can you do about that? The state could be constitutionally obligated to counteract this to a certain extent. You could also argue that it's up for, if there is a father and mother, it's up to the couple to organize themselves and agree on its distribution. But for people with a traditional understanding of who they are, this might be not very realistic. But there is this factual effect. This is not to be denied, that the burden of women has been a bit higher during this pandemic.
Desafortunadamente se nos está agotando el tiempo, entonces voy a formular el último conjunto de preguntas englobada. Hay una preocupación o hay una inquietud general sobre cómo funcionó el sistema de administración de justicia alemán durante la pandemia, cómo respondieron los jueces o la organización judicial a los desafíos de la adjudicación. Y vinculado con esta preocupación por la administración de justicia, usted se refirió a un juicio consecuencialista que tendría que hacerse en relación con las medidas que se toman para contrarrestar los efectos del virus. Entonces hay un conjunto de preguntas sobre cuál es el estatus normativo jurídico de estos juicios consecuencialistas y que si hay como una obligación judicial de plantear las decisiones, los fallos, los argumentos en estos términos.
Yeah, thank you. Well, consequentialist approach is, why did I mention that? I mentioned that because this was my plea, so to speak, to understand the pandemic and the illness, to understand whether a means we employ has actually a positive effect. A positive effect is suppressing infections. Now we need to know that, because otherwise what we do is we design measures who do not help. And measures who do not help but limit liberty are, from the point of view of rule of law and fundamental rights, a catastrophe. And this is particularly important in the case of a pandemic with an unknown virus. Because with the plague, for example, Yersinia pestis, the medieval plague, we know this illness. We know, so to speak, automatically there is knowledge which measures help and which don't. Now, from the outset, for example, there was much emphasis on washing hands. And no one realized that actually aerosols play an important role. Now, if you have a measure that basically requires you to wash your hands every hour for 20 seconds with soap, you know the rules, they have all been advertised, requires you to do that. It may prove at the end of the day that the effect in preventing transmissions of COVID-19 is actually zero. It doesn't really help, because it may be, I'm not claiming this, but it may be that smear infection isn't the problem at all. And in that sense, designing measures is consequentialist, because washing hands, well, it's generally good to wash your hands now and then, yes, but in terms of preventing this pandemic, if it doesn't help, then actually the measure, the means, wash your hands, the legal obligation, doesn't help. And this consequentialist approach, we need this for new challenges, because we need to understand the logic of the empirical world. What happens? What is cause and effect? What do we have to do to make things better? This is actually realized, and now no surprise here, by the principle of proportionality in the broader sense. Because a measure that has no positive effect for the purpose for which it is designed, but limits liberty, is actually not suitable. Suitability in this three-pronged test isn't fulfilled. So it's basically applying proportionality that helps you in doing this, in developing this consequentialist approach. And obviously, if our knowledge is limited about the disease but grows over time, obviously we have to realize that we made an honest mistake at the outset, that we thought, if this is the case, washing hands really helps. If it doesn't, well, it has to go as a measure. So in terms of constitutional theory, this consequentialist approach is realized by and reflected in the principle of proportionality. Now, German courts, there was the word concern in the question, and I don't know whether I would agree to the concern. Now, we will probably talk in this series of lectures at some point about the distribution of competences between the federal level and the state level. Now, many measures are designed by regulation at the state level, which means that German courts are competent to declare these regulations null and void in the case of unconstitutionality. Now, many German courts are competent themselves if this is a regulation. If it is actually parliamentary statute, now there is centralized constitutional review, and they had to refer the case to the Federal Constitutional Court. Now they can decide themselves. And there were a series of different decisions where German, usually administrative courts, found that this or that aspect of a state, we have 16 states in Germany, of one of the states' measures, is a whole bundle or cluster of measures, that one or the other aspect proved unconstitutional. And in such a case, for example, no effect but harm to liberty, they would not hesitate to declare this aspect of that measure unconstitutional and therefore null and void. And this happened. And well, of course, you can always have, so to speak, to some extent, reasonable disagreements about how to balance liberty and protection in certain contexts. There may be different opinions, but overall, my impression is that German courts had a relatively reasonable and middle ground, so to speak, in respecting the government's decisions, but where they found there was clear evidence that there was harm done without use, or use was bought, so to speak, at a disproportionate cost in terms of liberty. They didn't hesitate too much and interfered with these measures. And in some cases, the states then changed measures to a certain extent, or they just skipped it altogether. But this, I think, has been a very reasonable and a very reasonable debate between the governments and the courts. So I feel, as a citizen, which I also am, not only law professor, as a citizen, I feel well represented by the administrative courts. While as a law professor, I might disagree now and then, but as a citizen, I'm perfectly happy.
Muchas gracias, profesor. Desafortunadamente, el tiempo se agotó. Hay muchísimas preguntas y esperamos que muchas de ellas puedan ser resueltas a lo largo de la semana. Afortunadamente, este es un conversatorio que va a durar 4 días, entonces no se desanimen, que todavía sus preguntas están sobre la mesa. Le queremos agradecer muchísimo por la iniciativa, por esta charla que combina aspectos jurídicos, pero sobre todo aspectos de preocupación general por la enfermedad y sus impactos. Le queremos agradecer también a las personas que nos acompañaron por redes sociales. Los invitamos a que sigan con nosotros a lo largo de la semana y les contamos que mañana, 23 de marzo, va a estar con nosotros el profesor Carsten Becker y nos va a hablar sobre la constitucionalidad formal de las medidas contra la pandemia por el COVID-19. Entonces, de nuevo, muchas gracias, los esperamos mañana y que tengan una muy buena tarde. Hasta luego.
Thank you very much. And thank you for the good set of questions. Thank you.
Ya están fuera.
Perfecto.